Hello, everyone. Welcome to the first day of the rep training program that the JR and TNE marketing programs are putting together for the sales team for the next couple months. We thought over this time is an opportunity for us to create some of the marketing materials that we always wanted to do in the past, but we didn't have time to do. For my session, I wanted to focus on the Triathlon Flex Rod, and the reason being is that this is a clear advantage that we have over the competition. When a surgeon does a total knee arthroplasty case, usually his first step is a distal femoral cut, and that's using a straight rod. It is so, especially if they're a competitive surgeon using a competitive system. But when they do this, it doesn't allow any consideration of the sagittal plane. So it's trying to solve a three-dimensional problem two-dimensionally at a time. So all they can really focus on is varus valgus, and at the end of the day, getting post-op such that you have a straight knee. But the distal femoral cut and the correct orientation of it is so critically important because it defines everything afterwards. It defines the size of the component, it defines the kinematics, it defines the patellofemoral tracking, it defines the efficiency of the quadricep mechanism. So what I hope to do here is I'm going to go through a PowerPoint presentation that's going to help you to communicate the benefits of the Triathlon Flex Rod to your surgeon customers. So a little bit about the history first. So we launched Triathlon in 2004. And in speaking with Scott Logan, he was in a case with a surgeon that was used to using Duracon, and they're converting them to Triathlon. And during the case, they notched the femur. And when they sized it, they also felt that the femur needed a component that was 2 sizes bigger than the tibia. So after the case, he took a look at the pre-op x-rays to try to figure out what went wrong here with this case. And then he realized that the bow of the femur was quite pronounced. It was a patient that was of Asian descent, which the literature shows that that patient population group does have quite prominent anterior bowed femur. Often they call it a hockey stick femur, where the distal part of the femur is quite flexed. When he looked at the post-op films, he saw that the femoral component was placed in considerable hyperextension, which was the reason for the notch as well. So he went back to the team, and that year that they created the Triathlon Flex Rod, and in 2007, they launched the Triathlon Flex Rod. And slowly, year by year, the adoption of the Flex Rod has taken place, that a lot of our surgeons are now using it, but not all of our surgeons are using it. And I think it's very important that they should be using it. So one of the benefits of the Flex Rod is sizing. And I think this is the component here that most of us are a little bit more comfortable speaking about. It's very straightforward. So with this image here, you see a straight rod, and you also see a flex rod. So let's ignore the flex rod right now. If you're using a straight rod, your distal femoral cut is going to be this cut here. If you then use a flex rod, or instead use a flex rod, your cut is going to be in a very different orientation. This is very obvious. But what we find is that if the cut is done in a hyperextended position, the AP runout tends to be longer than the AP runout if it's more in an anatomical flexed position. And just putting these two lines together just for a visible representation. So when the surgeon does his case and he sizes, he's only thinking AP, but he doesn't have an appreciation for the ML dimensions of the components and how it relates to the anatomy until he's trialing. And at this point, if the sizing was done in a hyperextended position, then he's putting on a size 4 implant, for example, which is creating a little bit of overhang potentially, where maybe this was an anatomy that if we used the flex rod, it would have shown that it should have been a size 3 and that the ML dimensions worked well with the anatomy of that individual as well. So we have competitive reps that talk to our surgeons all the time that talk about that the limitation of our system is that it only has a 1 up, 1 down sizing compatibility, where their systems may have 2 up, 2 down or more. My response to that is, if you're using a flex rod, usually that you're going to get a 1-to-1 ratio, where you're going to get a size 4 femur and a size for tibia, and sometimes you go up one size, sometimes you go down one size. So with their systems, they can go up or down a couple sizes. I go back to our sizing was correct in the beginning as far as the AP/ML dimensions that we created from the start. The other real benefit of the flex rod really comes down to kinematics, and this is something that we probably don't talk about enough. So again, imagine that I have a straight rod here, and then I do my first distal femoral cut. Well, that's going to position the single axis of rotation of the implant to be here, for example. Now, that being said, the single axis of rotation of the anatomy might be here, represented by the blue dot. Everything that we talk about with the benefits of the triathlon knee and the single axis rotation is all dependent on placing the single axis of the component as closest to the single axis of the anatomy as possible. If we have the flex rod, we're going to do a single axis of rotation here, which hopefully marries up better with the single axis of the anatomy itself. Because what we're trying to accomplish here is this picture. The collateral ligaments insert at the single axis of rotation of the anatomy. So if we can marry the single axis rotation of the femoral component in the same spot, so everything that we talked about in the past, we're going to get the ligamentous isometry, the same tension of the ligaments as you go from an extended position to a flexed position. That's going to allow you to have ligamentous stability in mid-range as well as throughout the range. That's going to make it easier for the surgeon to balance the flexion extension gaps. It makes it easier for the patient to have a better proprioceptive sense of their knee or sense of normalcy. So for some of the younger reps maybe that don't understand what proprioception is that it's awareness of your body in space. So imagine my eyes are closed and somebody bent my hand forwards. Well, I know that it's forward because I can sense that, because you have neural receptors in your ligaments that give your brain the feedback of where your body is in space. So if you're an older patient that's trying to go down a flight of stairs and you're weight bearing on one leg and you are trying to take your second leg down to the step below, and now you're in single leg stance, as you start to bend that leg that's in single leg stance, if your ligamentous isometry is not maintained throughout that flexion extension movement, it may give that patient an altered sense of what their proprioception is. So we always talk about the older or the younger patient and how our knees address those high demand patients. But the majority of our patients are actually older patients. So you can imagine how a lack of stability or a lack of proprioceptive sense affects them as they're doing activities of daily life, how it affects their balance and how it affects their confidence to be able to do the things that they want to be able to do. Now, the other piece too is that when we look at the flexion extension, as far as where it places for your kinematics, I'm going to go back here. Again, if you think about this, you can see that when we talk about the flex rod, we're not just talking about flexing or extending about one axis similar to where it would have been if you used a straight rod, but there's a translation piece here as well, right? So you can see that anatomical representation of the single axis is a little bit posterior as well. So this is key to finding that exact place. So if I skip forward again, you can see here, this image is really a representation between a multi-radius and a single radius implant, but it also helps me demonstrate my point. The one on my left is a single radius. You can see there's a longer lever here. If there's a longer lever for the extensor mechanism to act upon, it's going to take less force of the extensor mechanism to create an extension movement compared to a multi-radius component that's got a shorter lever arm. If we use a straight rod, which takes the single axis rotation a little bit anterior, the same thing would happen in comparison to a flex rod. The flex rod is going to make an improved extensor mechanism. The next slide here just shows some x-rays of the same patient of using a straight rod and a flex rod. And again, just making the point of how vastly different that orientation at that first cut is going to be, which is going to dictate all the rest of the orientation of the rest of the component. If we look at the surgical technique here, the goal here is to take a IM entry point here such that it is just anterior to the PCL, close enough that you're not compromising the PCL either. You're going to use the IM drill from the old Scorpio set, that's 3/8 inch. And when you drill, you're going to make sure that the shaft of the drill is parallel to the shaft of the exposed part of the distal femur that is exposed for the surgeon to be able to see. Here's two pictures. The one on the left, the X-ray, is basically showing a femoral component that's probably a little bit hyperextended. And you can see that because if you use the pegs as your reference mark, you can see it's not parallel to the shaft of the femur. It's pointing downwards a little bit, where the drawing representation there shows that the pegs are more in line parallel to the shaft of the femur itself. Now, when your surgeons start doing the flex rod and they're used to the straight, then what they find is that their X-rays are going to look a little different. They're going to be a little bit more flexed. And they should be expecting this, but when they first see it, it throws them a little bit. And I have had these questions in the past, especially with the PS component. And what I want to point out here is that the box hides the peg, so you can't see the peg for your orientation. But the box itself has an angle relative to the distal cut itself. So it might look even more flexed than it actually is compared to a CR component. So my only point here is that if you're looking at flexion of a PS component, you should really be looking at the posterior condyles more so than you're looking at the box itself. This is a poster that was written by Kirby Hitt, who is the designer of the Triathlon knee. You can see it also has Evan Leibowitz on it and Scott Logan. Both are engineers at Stryker. Obviously, everybody here is quite familiar with Scott Logan. So in this paper, they retrospectively looked at 641 patients. 364 of those patients had a TKA used with a flex rod. The rest were with a rigid straight rod. And what they found from a sizing standpoint was they used the larger sizes, size 7 and 8, far less with the flex rod cohort than they did with the rigid rod cohort. The flex rod cohort, they had a decrease in the use of size 7 and 8 by 14%. At the same time, obviously, their use of the mid sizes, sizes 4 to 6, increased by 13%. When they looked at the range of motion, comparing the two groups, the flex rod and the straight rod, and again, at the end of the day, we're talking about a triathlon knee, so all the results were very good. The point here is with the flex rod, it can be even just a little bit better. If you look at the range of motion from the pre-op to 2 years, the percent change at 2 years was greatest with the flex rod, with a 28.3% improvement compared to 22.2% with the rigid rod. When they looked at KSS pain and motion scores, at 2 years, the percent change with the flex rod was 160% improvement compared to 143% with the rigid rod. This was a white paper that was done by Evan Leibowitz and Scott Logan, and basically it's just looking at putting metrics around the bow of the femur of different ethnic cohorts. So here what they measured was the circle radius mean, and what you need to know there is the lower the number, the greater the anterior bow of the femur. So of the 600 CAT scans that they looked at, when they looked at the Asian cohort of those, the circle radius mean was 88. Compare that to the Caucasian cohort, it was 99. So again, it's just showing that between different ethnic backgrounds, the Asian population has a much more significant bow than other cohorts. So within this Asian cohort, what they did is they took 3 of the CAT scans. The top one is representative of the patient that had the least amount of bowing. The middle one is an average of the Asian cohort, representation of the average bow. And then the bottom one is the greatest bow that they found within the Asian cohort. And for the femur that they showed the least amount of bow, they measured the difference between the degrees between the straight rod and using a flex rod, and they showed there was no difference. And this really brings up the point of, you know that there's some surgeons out there that they only use the rigid rod when they know there's a large bow in the femur. I recommend that you use the flex rod for all your femurs. So if it's straight femur, then it won't flex. So go ahead and use it anyways. I would tell you to take the straight rod out of your sets unless you're using it for IM alignment. So the middle bone there, which was a representative of the average of the Asian cohort, the difference between the straight rod and the flex rod was 4.5 degrees, which is pretty pronounced difference orientation of the femoral component. And then the last femur, which was the greatest bow, was a 7.5 degree difference. As far as your resources, here, if you go onto SailStream, you can see that there is some content on FlexRod. This PowerPoint presentation is a tool for you. Hopefully you can engage your surgeons in discussion with. You've got the surgical technique, which is outlined here as well. You can contact Hillary for any of these. Here are 3 papers, which is really 2 papers. The first one on the left is talking about the different ethnic cohorts. They measured the amount of femoral bowing. The second one is the poster of the data that I just went through, written by Dr. Kirby Hitt about range of motion and function. And the third one is just an extension on that that was published, and it just goes into greater details. So here I have the video that's going to go through what I believe is, I'm hoping, best practices on how to use the flex rod. I've been in a lot of cases across the country. I see the flex rod being used, and sometimes I don't think it's used exactly the way that it's supposed to be used. So that was the point of trying to create this. I've got to change something on my audio here, and then this should work fine.
Hi everybody, I am going to go through a sawbone of how to use the Triathlon IM Flex Rod. So the first thing that you're going to do is that you're going to ensure that your drill bit is the old Scorpio drill bit, which is a 3/8 inch. It's important that you're using a small hole to use with the Triathlon IM Flex Rod. You don't want to use the step Triathlon IM drill because it's too big in the proximal part. And the reason being is that if you drill a big hole, and a lot of surgeons are used to drilling that hole and starting to toggle, when you put the flex rod in, what will happen is that if you've got a big hole, then the flex rod is just going to move up towards the anterior aspect of it, and then you have really no difference between using a flex rod and using a straight rod. So this old drill bit is very important. So as far as the surgical technique, when you drill the initial hole, what you're going to do is that you want to be as close to the PCL as possible without compromising it, obviously, and you're going to be a little bit medial to the midline. In the sagittal plane, what you're going to do is that you're going to look at the shaft of the drill and make sure it's parallel to the shaft of the femur of the distal aspect that is exposed. So you're going to go ahead and do that. Now from there, you're going to take your flex rod, and then you're going to use your varus valgus alignment guide. I'm going to put these 2 together. And the interesting thing about doing a total knee arthroplasty is it's a 3-dimensional problem, but we're approaching it 2-dimensionally at a time. We're going to try to determine the varus valgus alignment without consideration of the sagittal plane at all. So whether it's flexed or whether it's extended. But that's why the Triathlon Flex Rod, as simple as it is a real advantage of the entire system that our competition doesn't have. So what we're going to be able to do with the flex rod is, in determining our varus valgus, we're going to put the flex rod into the hole. Now you can see when it's flat here at the most distal end here, it becomes cylindrical again. What I see a lot of surgeons doing is that as they put this into the hole, they get so far, and then the cylindrical part butts up against the anterior aspect of the bone. So to get it in, then they slap hard. And by doing that, they change from a circular hole to more of an oval hole, which all that does is allow the flex rod to rise anteriorly, which is what we don't want. So I tell them is that as they get close to the hole, make sure that they're putting some downward pressure on the T-handle such that that goes into the hole and doesn't make it any bigger. So we're going to put it in like this. As we get close, I'm going to use 2 fingers here. I'm going to apply a downward pressure and make sure the cylindrical part goes into the hole without creating an oval. Now, as I'm in this position, you can see I'm maintaining this downward pressure. I'm going to continue to do that. It's probably easiest if the surgeon assist then takes the distal resection guide, puts it into the varus alignment guide, and then as a surgeon, I'm going to make sure that this remains up against the bone, and my assistant can drill the 2 holes. And by doing that and maintaining the downward pressure with my 2 fingers, then we're going to be able to do our varus valgus alignment, but also with consideration of the sagittal plane, ensure that we are creating a little bit of flexion, which is going to be the best sizing of the femoral implant, and also the best kinematics as we outlined in our PowerPoint presentation. Just again showing you the same thing from the side. I'm looking at the cylindrical portion here. As the rod is going in, I apply a little bit of downward pressure to make sure that cylindrical part goes into the hole without making it bigger. I maintain that downward pressure, and then the surgical assist will put this in. I hold it down, and the assist does the pinning. And we have our 3-dimensional orientation of the distal femoral resection. Thank you.
So with that, the key takeaways for me is I really believe in the flex rod is the best experience for our existing surgeons. So any of your surgeons that are not using the flex rod yet, I'm sure they're having great experience with triathlon, but I think they can have an even better experience with triathlon. So I would go ahead and engage your customers with that conversation as well. If you ever get a trial with a competitive surgeon, I think this is extremely important because it's a differentiator. And when we have those conversations with surgeons, they do understand it in the sense that for the first time, they can consider the sagittal plane when they're trying to do the first step, which is that distal femoral cut. And we can explain everything that is important about how that alters kinematics, sizing, everything else. And it goes into our whole single axis rotation story. So I think there's a huge benefit there. And then you can try to address any concerns that the surgeon has about our 1-up, 1-down sizing and the fact that our sizing is excellent. And when you use the flex rod, most of the time you can get a 1-to-1 ratio. So with that, I would like to thank everybody for listening to this presentation. And I hope everybody is doing well with their families. All the best.